Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast I'm joined by our deputy editor Nick Bostock.
Hello.
And senior reporter Kimberley Hackett.
Hi everyone.
To talk about the latest news affecting primary care. Coming up, we're talking about NHS England's plans to pilot new ways of working in general practice in a bid to optimise the GP operating model and what this could all mean for the future. We're also looking at what the BMA might want from the next GP contract. We'll be looking ahead to next week's UK Conference of Local Medical Committees and discussing some of the key motions up for debate. And we're talking about the state of GP premises and some possible good news after updated premises cost directions were published last week following many years of delay. Our good news story this week is about an outreach project that's taking health services out into deprived communities. That's all to come on this episode of Talking General Practice. First up, we're talking about NHS England's plans to pilot new ways of working that aim to optimise the general practice operating model. The plans will be happening with a small number of primary care networks in different integrated care board areas in England. Nick, can you explain what this is all about and where it's come from?
This all came from a letter that NHS England sent to integrated care boards, ICBs, at the start of May. The letter said a group of ICBs had come forward to ask if they could pilot new ways of working in general practice, and it basically confirmed that their proposal had been accepted. NHS England's letter said that this group of ICBs wanted to work with a small number of primary care networks to test, and this is a quote, operational changes and improvements that would optimise the general practice operating model. And it said the aim of these trials would be to look at ways to help general practice meet increasing demand and complexity across urgent and proactive care. And broadly, this is all about trying to work out how ICBs can deliver the kind of vision for general practice set out last year by NHS England in a document called the Fuller Stocktake, which we'll come on to a bit more in a minute. And some of the important context here is that in the last few months, we've seen some controversy around different areas, in particular northwest London, trying to roll out new ways of handling appointments in general practice, which are linked to the Fuller Stocktake. In northwest London, the ICB wanted to separate out same-day appointments in general practice and deliver them at scale, something that would effectively have broken the link between patients and the practice they're registered with when it comes to same-day appointments. And there was a big outcry from patients and GPs in the area. There have been some outcries in other areas as well, which Kimberley's written about. And this letter about piloting new ways of working basically seems to be NHS England's plan to resurrect what ICBs have been working on around new models of care, basically trying to get it all off the ground again after the controversy the first time around.
The letter says that the pilots will be focused on primary care networks as opposed to individual practices. So it really is about working at scale, isn't it? What sort of things will these pilots be looking at?
As you said, it is about working with PCNs and certainly in part at least about working at scale. The letter says the pilots will use data to look at demand and workload and how to respond to that. They'll also look at things like using digital tools to support general practice, which is echoing some of the stuff from the Improving Access to General Practice plan. And there's a line in there about trying to reduce bureaucracy. And one of the ideas is to test flexible staffing models, which I suppose could involve ideas that have been promoted before by NHS England, like pools of locums or other staff that might be employed regionally and then deployed to support practices when they're under pressure. One of the aims of the pilots that really speaks to the point about a vision of working at scale is for PCNs taking part to trial dedicated multidisciplinary teams that could support patients with more complex needs. That could suggest almost a separate service for complex patients within general practice. The letter also talks about looking at how extra capacity can be used most efficiently in general practice, and then there are some broader goals that could have huge implications. We're going to come on to this in a minute, but the pilots will also look at what general practice and PCNs will need in the longer term to deliver the vision set out in the Fuller Stocktake.
Yeah, the Fuller Stocktake. So for people who don't remember, that Stocktake was a report that came out in the middle of 2022 that looked at how to integrate primary care in England. It was effectively a stocktake of the current state of primary care and then recommendations on how to accelerate integration. And that was carried out by Dr. Claire Fuller, who, as a GP and at the time, was Chief Executive of Surrey Heartland Integrated Care System. Since the report was published, Dr. Fuller has gone on to become the primary care medical director at NHS England. And Nick, you and I did a podcast when that report came out, looking at it in quite a lot of detail. We can put a link to that in the show notes, maybe if people want to go back and listen to it from the archive. But for those people who don't remember, what exactly did the Fuller stocktake say? Which aspects of that vision do you think will be particularly relevant to these pilots?
Yeah, it's worth remembering that the full title of the Fuller Stocktake report is actually Next Steps for Integrating Primary Care. So that vision of closer integration of GP practices with each other and with the wider health system and doing more at scale is very much at the heart of it. The Fuller Stocktake said that primary care capacity needed to increase up to a point, but primarily it argued that it's time to rethink how primary care services should be designed for different groups of people. And it said that continuity should be retained as a core strength of general practice, but it argued that while growing numbers of people with long-term conditions, with complex needs, need personalised care and support, others normally in good health would prioritise faster access. And so it said access to care and advice should be streamlined for people who get ill but only use healthcare services infrequently. So that's the group we've seen targeted through same-day access initiatives in recent months, which aim to scale up rapid access, not necessarily through your own GP practice. And then Fuller said there should be more proactive, personalised care from a multidisciplinary team for patients with complex needs, such as people with long-term conditions, which sounds very much like the language in the recent letter to ICBs. The Fuller report also talks about ICBs creating a single system-wide approach to managing integrated urgent care to guarantee same-day care for patients and a more sustainable model for general practice or for practices. It also called for the government and NHS England to update legislation, contracts and so on to support the shift, to enable and support these sorts of new models of integrated primary care. Ultimately, I think all this shows perhaps how far apart NHS England and the BMA are in terms of their sense of the future for general practice. On the one hand, the BMA basically says the current GMS contract isn't broken. It just needs funding restored to a level that makes general practice able to deliver the services patients need, and that GP practices should still be looking after the whole of the population, whether it's people who need same-day access or not people with long-term conditions, and for those who are. NHS England, on the other hand, looks intent on pressing ahead with a model with a major overhaul to try and deliver services in a very different way, perhaps in the hope that it'll enable primary care to cope within the existing financial constraints.
Oh, it's quite interesting, isn't it? Because this idea that everybody wants an appointment as quickly as possible and they don't care who it's with, it'd be interesting to see where that comes from, because I think lots of people probably want an appointment maybe more quickly than they can actually get one, but they don't necessarily want it the same day. They might be prepared to wait a couple of days if it could be with their practice. And I suspect there's a lot of people in that group that NHS England sort of suggested would just don't care, would rather be seen by their own practice, not necessarily maybe the same day, but maybe quicker than having to wait 4 or 5 days. And I don't know. I mean, I'm just kind of a bit sceptical about whether some of these ideas actually hold water when you put them up to real life. But anyway, do we know who's going to be involved with these pilots that NHS England is supporting?
We don't know too much at this stage about which ICB areas will be involved, other than that Suffolk and North East Essex ICB will be among them, because its chief executive is coordinating the plans across ICBs that are going to take part. The letter from NHS England suggested that it would be a small group of ICBs leading on this, with a small number of PCNs in each area taking part. There's a bit of detail on the sorts of criteria they'll be looking at to select PCNs. The letter said ICBs need to make sure they choose PCNs that cover locations with different demographic and geographical characteristics, and then implement the changes in a consistent way across those. So presumably they'll be able to evaluate outcomes in a comparable way.
Do we know what GPs think about all of this?
The response from the BMA GP committee was basically that if the government and NHS England really want to optimise general practice, they should start by funding it properly.
Yeah.
They said that it made no sense to try out new, untested ways of delivering general practice services while at the same time ignoring calls for massive real terms cuts in practice funding to be reversed. The BMA says that practice funding has been eroded in real terms by more than 50% over the past 15 years. And just over the course of the 5-year contract that came to an end earlier this year, funding has continued to fall. In negotiations earlier this year, the BMA told the government that general practice needed an uplift of 8.7% just to take practices back to the financial position they were in 2019 when the 5-year contract began. But as we know, obviously in the end, the government imposed an uplift of 1.9%, which led to the BMA contract referendum, which we've talked about on the podcast, and the BMA declaring earlier this year that GPs are now in dispute over the current contract, and which, as things stand, is likely to see GPs taking industrial action later this year.
Interestingly, since details of that pilot were published, we've also seen the BMA GP Committee for England chair, Dr. Katie Bramall-Stainer, tweeting this week about what she thinks needs to be in the next GP contract. We've talked on the podcast before about how we could potentially see quite a big overhaul of the GP contract from April 2025, a lot of which will obviously depend on who wins the next general election. I suppose the pilots we've talked about here very much set out the sorts of things that NHS England would likely want to prioritise in any future GP contract, but clearly that might not be exactly the same as what GPs would want. What did Dr. Bramall-Stainer say she thinks needs to be in the next GP contract?
First off, I should probably say that these comments about what should be in the next contract, there were comments that were made on social media. They're very much top line. It's not necessarily a sort of fundamental picture of what the BMA wants or will be negotiating for. But Dr. Bramall-Stainer set out 3 key demands for what she called a new substantive GP contract. Just on that point, we knew that this year's contract for 2024-25 would be a stopgap after the 5-year contract that ran from 2019 to 2024. So this idea of a substantive new contract is probably a reference to what the BMA GP committee wants from the next contract that brings a more significant change. It's not necessarily the 25-26 one or even the 26-27 one. Dr. Bramall-Stainer has said previously, in fact, that general practice might need to wait until something like 2028 for a really significant contract change. And that's obviously, as you mentioned, that the current Parliament is coming to an end this year. Clearly, there's a good chance that we may see a change of government in the upcoming general election. So 2028 was an estimate of how long it might take to agree any real big shift with potentially a new government and a new amount of funding available for the NHS potentially. But the 3 points she outlined that should be in a future contract were a recommended limit on the maximum number of patients a GP should be expected to look after. Also a target share of overall NHS funding that should go to general practice, and then a plan to set out what exactly general practice is expected to deliver, and then to work back from that to cost what it should be paid to actually deliver those services. In terms of patients per GP, there are currently nearly 2,300 patients for every fully qualified full-time equivalent GP in England, and that's more than 25% above a level of 1,800 patients per GP that some LMCs and others recognise as a safe limit, and that 1,800 figure broadly lines up with the current BMA safe working advice for general practice. Interestingly, Dr. Bramall-Stainer said the current safe limit should change because of increasing patient complexity and rising demand. Roughly 2 in 3 people aged over 65 have multimorbidity, according to NHS England, and the number of patients on practice lists aged over 65 are rising much more quickly than the population as a whole. In fact, for over 75s, the rise is even faster. So GP work is becoming more complex, and there are more patients registered with each GP practice on average who consult more often than younger patients. But obviously, if that safe limit comes down, say it comes down to 1,700 patients per GP or 1,600 patients per GP, general practice needs even more GPs than it would need to bring it down to the current safe limit. And in recent years, the government's completely failed to deliver on promises to grow the GP workforce. In terms of the target share of funding, both the BMA and the RCGP have talked about wanting an 11% share of NHS funding for general practice, and that's up from a share of around 8%, the current level that people quote varies depending on which estimate you look at and what you benchmark it against. And Dr. Bramwell-Stainer talked about wanting to set a target share and then move towards that over the course of a contract, or possibly even multiple contracts, I suppose. Final point around setting out more clearly what's expected from general practice and costing that and delivering the funding for it. LMCs have voted in recent years for a return to an item of service contract. And the motivation for that is the argument that the current contract has become an all-you-can-eat buffet in which general practice delivers unrestricted workload for a fixed fee. And clearly, as funding's been eroded in recent years, that's made life harder and harder for practices.
All of this stuff is really interesting. I mean, they're really big changes that you'd be looking for. And yes, they're not necessarily something that would come in as quickly as next April. They're things that you would be pushing forward towards a big kind of overhaul of the contract, perhaps the type we kind of saw in 2004, when there was a massive shift in the whole way GPs and practices were funding. But it is really interesting. I think that there's a lot of recognition from lots of quarters that primary care's share of the overall NHS funding is not enough as we deal with an ageing population, with people with multimorbidity. You need more care nearer to home. And we did a podcast recently with the King's Fund, and we're talking about that, about how you move to an NHS that's built around community services as opposed to hospitals and a place where people actually want care. And you do need to see more funding going there. But the only way you can really do that is off the basis of a whole rising tide of funding for the NHS as a whole. So everyone's getting more funding, but then more of that funding, and proportionately more of that, is going to primary care, because you can never see people supporting the idea of taking money off hospitals to give to primary care. So it's really going to have to be part of a bold plan for how we sustain the NHS going forward, and how we think about what the NHS's role is as an ageing population and what the priorities are for the NHS as part of that. And that's a big project that a government has got to take on and has really got to grapple with. Before we move on, just to let you know that MIMS Learning Live London takes place on the 7th of June at the Business Design Centre in Islington. Organised by our colleagues on MIMS Learning, the event is free to attend for healthcare professionals working in primary care. This year's programme features streams across 4 key therapy areas: dermatology, women's health, respiratory and cardiovascular renal metabolic medicine, with expert speakers who'll provide you with actionable insights for immediate application in your practice. There'll be plenty of opportunities to ask questions and network with colleagues, and the event provides 5 hours of CPD. You can register for your free place at mimslearninglive.com. Next week, LMC leaders from across the UK will gather in Wales for the UK Local Medical Committee Conference on Thursday and Friday. The UK conference tends to focus on issues that are applicable across all 4 countries, so they're often quite broad topics up for discussion. But this year looks like there's some really interesting motions up for debate. The way the conference works is that a series of motions are discussed and then voted on, and those votes then guide the positions of the 4 GP committees in those particular areas, which would then be reflected in any discussions the committee's leaders have with governments or NHS England, for example. So, Nick, there's a lot of discussions about the financial position GP practices are currently in, because we know that's an issue in all 4 countries, and also a motion that relates to industrial action as well. What sort of things will GPs be discussing and voting on around that?
As we discussed earlier, the BMA says practice funding's been eroded by more than 50% in real terms since around 2008. That's an estimate for England, but we know that there's major financial challenges across the UK for general practice. As we've reported, that in England, again, I mean, the contract imposed on practices for this year could widen the financial black hole that practices are facing by around £50,000 or more per average practice. And there are a whole load of motions up for debate at the UK LMC's conference that reference underfunding of general practice, the catastrophic effect that's having on practices, and then basically what the profession should do about it. Some of the motions hit out at the imposition of contracts on general practice, as has happened this year and the 2 previous years in England, as opposed to, obviously, contracts being reached by negotiation between the BMA and the government, which is the preferred option. They talk about the impact of short-term thinking, the erosion of continuity of care in general practice, and there's a call for funding uplifts for GP contracts to be tied to inflation, with something like the triple lock that protects the value of state pensions. GPs really want to see more funding for general practice and are really concerned about the damage being done to GP services by the underfunding that there is at the moment. And in terms of what they want to do about it, that motions up for debate suggest potentially some pretty radical steps. One motion says that UK governments have failed to provide the necessary investment to ensure the survival of the GMS contract, and that the best option might be for the profession simply to walk away en masse. It says that that option could be more effective than industrial action, which is, we know that the GP committee in England is planning to push ahead with something like that later this year. But what follows on from that sort of suggestion is effectively a shift towards a dentistry type model for general practice with a far greater private element. And GPs are going to debate motions calling for the BMA to develop models that would allow practices to work outside the NHS and take on more private work. I mean, it's worth saying that in general, these sorts of motions calling for a shift to a more private model or towards more private consultations tend to fail at LMC's conferences. But they are a reflection of the real anger among the profession about the impact of a long-term failure to fund general practice properly.
That stuff about the private work, it could be quite interesting because obviously, as you say, this is a UK LMC's conference, and we have seen quite recently practices in Northern Ireland that started taking on private patients because the rules in Northern Ireland allow for you to be able to do that. Obviously in England you cannot, under the GP contract, you can't have private patients alongside NHS patients. It would be quite interesting, because I'm sure that what's going on in Northern Ireland and that sort of shift you've seen in maybe one practice so far, but it's obviously that's a big discussion in Northern Ireland. It'd be kind of interesting to see how that feeds into those debates. Anyway, Kimberley, let's bring you in here. Which motions from the programme caught your eye? You've written about a couple of them, haven't you?
Yeah, so I came across one of the motions from North Yorkshire LMC, who has asked for a debate to be held around the increase of patient aggression in general practice. It isn't really a surprise that this motion was put forward. I've only been in the role for about 6 months and I've lost count as to how many stories we have covered about patients being verbally and even physically violent towards GP staff. And in some cases, thousands of pounds worth of damage has been caused to premises during attacks. Currently, there is a service that ensures that violent patients who have been removed from practice lists can still access healthcare, but for a patient to be referred to what's called the Special Allocation Scheme, practices have to report an incident to the police. Now, GPs at the conference are going to argue that the criteria for referral to the Special Allocation Scheme should be relaxed. The motion also calls for an increase in funding for these violent patient schemes, as well as asking BMA GP leaders to lobby the government to impose more severe sanctions for perpetrators.
Yeah, it really is a problem that's become increasingly worse over the last few years, as you mentioned there, Kimberley. There's also a motion about physicians' associates on the agenda, which I think people will be following with interest, given the general discussions about PAs that are going on within general practice and within Royal Colleges at the minute, including the RCGP. The motion says the conference has concerns about the promotion of PAs in general practice and, I quote, condemns the use of PAs for anything other than administrative or simple procedure duties. It also says that delegates believe the GMC is complicit in a government agenda to create a cheaper and inferior delivery model of primary care by using PAs in place of GPs. And also there's part of that motion that says patients should be made fully aware of which healthcare professionals they are seeing before any consultation. I suspect the conference will back a lot of that motion, but it's always interesting to see what delegates have to say on these sorts of issues when they stand up and talk. And Kimberley, finally, there's another motion that looks quite interesting, which is about representation of GPs within the BMA. What's that one all about?
Lambeth LMC has raised concerns about the lack of GP representation within the BMA over the last 2 years. The LMC goes so far as to say that with the exception of the BMA GP committees, the BMA no longer adequately represents all GPs. GPs will also debate asking the BMA GP committees to consider GP-relevant motions passed at the annual representative meeting, but not to enact them unless they are consistent with the UK LMC conference policy. Included in the motion is a call for the BMA GP committees to prevent the union from making decisions about general practice by a body in which GPs are a minority. And the motion also explores the idea of a fund for a GP-specific trade union activity that sits alongside the BMA.
Yeah, that's quite interesting, isn't it? Because obviously the BMA is a massive union, and we know that membership among junior doctors and consultants and SAS doctors actually has increased significantly over the past year or so because of industrial action. So, yeah, it's interesting that GPs, LMC delegates are actually thinking that maybe that's something that could be a concern. Thanks, Kimberley. So we'll be reporting from the conference on Thursday and Friday next week, the 23rd and 24th of May, and you can find all the latest news about those debates and other things of interest that come up during the event on our website at GPonline.com. Don't forget, you can also sign up for our news email alerts on the website to make sure you don't miss anything.
So one of the other stories that we've covered in the last week relates to GP premises and the publication finally of updated premises cost directions. Emma, you've been looking at that. What exactly are the premises cost directions?
Yeah, well, this is the real technicalities of GP funding, isn't it? So the premises cost directions are basically the legal rules that govern how GP premises are funding. They're part of the overall legal framework under which GP practices operate, and they set out how payments should be calculated and paid to practices in England for everything related to premises. They cover practices that are owned by the partners and also those that are leased from third parties. We've been waiting a really long time for this update. I mean, this final version of the cost directions that was published last week, that was agreed actually as part of the 2019 GP contract, so the 5-year contract that ended earlier this year. But there had been discussions going on about changes that needed to be made to the cost directions since well before then. The last directions date from 2013, and the BMA has been really pushing for changes to them pretty much since they were published in 2013.
And there are some potentially significant changes to the funding practices can get for premises improvements, aren't there?
Yes, there are. So under the previous cost directions, the 2013 ones, practices could only receive what are called premises improvement grants from their commissioners. So this is basically NHS funding. They can only receive those grants for up to 66% of the cost of the development. So that's either for new builds or developments to existing premises. But under the new directions, commissioners now have the freedom to fully fund any premises development. So practices could get grants that cover 100% of the work that's going on.
The freedom, but not the money, importantly.
I'm going to come on to that in a minute. I mean, there's a few other flexibilities added to that funding as well. Practices will be able to use those grants to purchase land to extend any existing premises. Previously, they wouldn't have been able to do that. They still can't use any of that funding to acquire land or buildings for a new development. No, that remains the same as in previous directions. Practices may also be able to get grants for improvements that will reduce the environmental impact of the building. That's a new thing. And they can get stamp duty costs covered in certain circumstances as well. There's also been some changes to the way these grants are made. So when you get the grants, you have to effectively sign up to a minimum period of use in the premises, the length of which depends on the size of the grant you're given. And those time limits have been changed in the new directions. So they are now lower or the same for most amounts that would be awarded. Although for the smaller amounts and the very big grants, you know, we're talking over £1.2 million, those big grants, the tie-in is actually slightly longer. And those time limits also apply to rules around rent reimbursement abatement. So basically you get reduced rent reimbursement from your commissioner if you get one of those grants. So in most cases, the time that applies for will have come down as well. So changes around premises funding, broadly good news, but, and as you mentioned there, Nick, and it's a really big but, all of these changes will make very little difference to premises unless there's actually money available to pay for improvements. And this is the point the BMA has made. It says the updated directions are very welcome. They've been pushing for these changes for years. But the BMA GP premises lead, Dr. Gaurav Gupta, said that if GPs go to their commissioners and say, I want to apply for a grant to improve my premises, they're likely to be told there's no money to do it. You know, his point is that unless the government provides ICBs with funding, no one can improve their surgery. Just on that, we know many practices desperately need improvement. A major survey by the RCGP last year found that 4 in 10 GPs work in practice premises that are unfit for purpose. You know, some reported water leaks, mould, or having to block gaps in windows with tape. We talked about that on the podcast at the time, Nick. You know, as part of its manifesto for general practice, the college has called for at least a £2 billion investment in premises to give every patient access to modern, fit-for-purpose buildings. On top of all that, the NHS Workforce Plan that set out plans for a huge expansion in the number of people working in primary care, big expansion of GP training, all foundation doctors spending time in general practice, more people coming into the multidisciplinary team. All of these people need space to work and space to train in. And we know that is just not the case in a lot of practices. The struggle with the room rota and finding places to squeeze everyone in across the week is already a major headache for lots and lots of practices managers. And that's just going to get much, much worse unless the government, or probably more realistically, the next government, commits to spending money on improving the primary care estate.
Imagine if the government had actually recruited 6,000 GPs as well. Are there any other changes in the directions that we should be aware of?
Yeah, there's quite a few other changes. If anyone listening to this does want some more detail, I'd point them to an article on our website, GP Business. So that's GP Online's sister website, by Bryn Morgan, who's a partner at the healthcare specialist law firm Hempsons, where he talks through the key changes and how they're likely to affect practices. It's a really useful article, and I'll make sure we put a link to that in the show notes. One point that article does make about premises development and improvements, and it's something actually other experts have said to me as well over the past couple of years, is that because there is so little money around at the minute for improvement grants, if any money ever does become available, it is the premises projects that have strong business cases, setting out the reasons they need the improvements and really detailing how those improvements will benefit the wider healthcare system. It's those projects that are most likely to get funding. And Bryn points out in his article that when we're talking about benefits to the wider healthcare system, ICBs are probably wanting to see plans that would push forward the integrated care agenda. So that's something practices might want to bear in mind. That's actually not something that's changed as a result of the new cost directions, but I just thought it was worth mentioning. Anyway, in terms of other changes, there are some changes around rent reviews that could potentially make the process a bit easier to navigate. The other thing is that ICBs won't be tied to just using the district valuer to conduct rent reviews. They can use any qualified and registered surveyor from now on. There's a real backlog of rent reviews in some areas, so that could possibly be a welcome development if more people can carry out these reviews and ICBs make use of those changes. And again, it means other people could be involved in valuations that are needed for funding applications. So if there is any money around for improvements, that could help avoid any delays there. The directors also have some provisions in there for last partner standing issues. So there's a completely new section about what happens when a practice terminates its contract and there are outstanding lease liabilities. NHS England is going to be producing a protocol, apparently, which sets out what happens to the lease in those situations and whether it's taken on by NHS England, whether it's assigned to someone else, perhaps the ICB. Those situations would apply if there was no one taking on the practice contract and the associated lease. But obviously, we haven't seen that protocol yet. I mean, there's quite a few other changes. But I think the point to note with all of this is that the directions are, at the minute, a series of legal statements on paper that have not been tested in the real world. So we've not seen how commissioners decide to interpret them or make use of them. We're expecting some guidance at some point from NHS England that might direct ICBs on exactly how they are supposed to apply these rules. But I think until the NHS starts to use them in practice, it's quite difficult to see the full impact that any of these changes will have. And that seems to be the general feeling from lawyers as well, that it really does remain to be seen whether they make any positive changes in the longer run. Before we go, we've just got time for our good news story. Kimberley, what's it this week?
In Scotland, the NHS Greater Glasgow and Clyde Health Board has converted a bus into a clinic that will provide a range of services including diabetes care for children and adults, gastroenterology and community-based services, and the bus will deliver this care directly to patients living in areas of high deprivation. The mobile clinical unit has been kitted out to contain a clinical area, kitchen and communal area for staff, and there will also be toys on board to keep young patients relaxed and entertained. Once it's up and running in June, the bus will be on the road every day, setting up at health centres and other public spaces and possibly public events to provide specialist care to hundreds of patients every year. And the kitchen will also be used as a show and tell space to help educate families on eating healthily on a budget. If the mobile clinical unit proves to be successful, then the health board said it will consider keeping it.
Well, that's it for this week. Thanks to Kimberley and Nick, and thanks so much for listening. If you're enjoying the podcast, please do think about giving us a rating or leaving a review. It would be most appreciated. I'll be back next week when I'm speaking to Tara Humphrey, who provides management support and training to primary care networks across England. And we're talking about what PCNs need to succeed and what the future could hold for networks. In the meantime, you can keep up to date with all the latest news affecting general practice and access a host of other resources on our website at GPonline.com.